Now with that, I want to say thank you to everybody for joining us today and bring up to the stage our first presenters. Bill Woodson and Steve Jenkins are two of our experts across enterprise strategy. When they're not at Executive Summit, they are presenting to many of your boards and executive leadership teams. They're going to do a bit of a different take on the State of the State presentation this year, with a focus specifically on scale. What does it mean? What does it not mean? And where do we go from here? All right, gentlemen.
Thank you.
Thank you.
Good morning.
Hey, guys. How are you?
It's a big group.
So welcome. And some of you have probably figured out, or you saw the news today. Today, Steve, is the anniversary, 1965, when Medicare was signed into law.
And you served in the Johnson administration,
Well,
correct?
I was thinking that that was actually the first year you and I did this presentation together.
I like my answer better.
And while we'd like to give Medicare to all of you today, we can't afford to because we had to buy lunch at the Four Seasons. All right. So let's jump in, Steve. A year ago, we talked about the new entrants in healthcare, and they've continued to kind of make some progress. And we've challenged you, your health systems, not to be distracted by their actions, but to pay attention and to respond accordingly in your local markets. Any major changes, I will tell you, with Amazon and the company Haven that they're part of with JP Morgan and Berkshire Hathaway, we've heard from just a couple of you actually in the room and online. The first kind of quiet agreements have been signed for discussion purposes of how you might work together with what they're going to try and do in healthcare. And then on the far right here, CVS Aetna has been starting to launch their health hubs. They've announced they're going to open 1,500 of them around the country. First markets will be in Boston, Dallas, Fort Worth, Florida, populations where there are a lot of chronic condition people need to be served, and also where there are a large number of enrollees and CVS stores. So these are living laboratories of what it will mean to kind of disrupt the primary care model, which is a very large topic for us right now. So we watch these. Many of you in the room sort of have watched these new players wade in, and other companies with private equity-backed dollars, and said we need to get bigger to compete with them. And we're going to challenge that thinking a little bit today, Steve. So let's jump in.
Exactly. So if last year was about all the distractions in the external environment, this year's Executive Summit, we want to refocus on ourselves and our business and our scale journey. We're going to take it in three parts. First, we want to briefly reflect on the path that we've come down in scale, what it's gotten for us and our patients and our communities, what it hasn't, the business yet to be done. Then we want to propose a somewhat different definition of scale that isn't just about assets and size. And then finally, we want to tease the rest of the day by looking at just three cases of what we consider the best of the best, organizations who found ways to wring value out of scale for all the constituencies considered. But let's start on the journey so far. Bill, we're 30 years now into a consolidation phase in our business and health services delivery. We want to briefly characterize what that's looked like. And then, as Aaron promised, we want to pierce a couple of myths, commonly held myths about scale and health services delivery. So let's start with this one. Myth number one is, consolidation in healthcare. This is about the very biggest organizations getting bigger, right? The bigger getting bigger. Well, let's look at the numbers, because that's not quite true. In 1990, here's the list of the top 10 health systems in the United States. And you see some familiar names, right? Kaiser Permanente is still with us. What they then called themselves Hospital Corporation of America, now HCA Health. We have representatives from HCA today. They're still with us. A number of the names. Now, let's fast forward 1990 to 2017 and see how they change.
That was exciting.
You want to see that one more time?
Yeah, that would be great. Yeah.
Let's look at it one more time.
Mic drop.
Top 10 list, 1990. Here's who they became in 2017. So the first thing you can observe just by the animation, it's a lot of the same players, right? And maybe the names have changed, and maybe there have been mergers among them, but a lot of the same names. We do have some new names on the list, like Sutter Health, like Providence St. Joseph,
Now Common Spirit, right?
Common Spirit, exactly. CHI and Dignity, now Common Spirit. But a lot of the same names. So next, let's look at, well, in 1990, those top 10 health systems, 8.9% of personal health spending flowed through those top 10 health systems. A couple of years ago, 2017, what was that number? 9.5%. The needle has barely moved, right? For all of the consolidation of the last almost 30 years, for all of the activity among the names on those two lists, the proportion of health spending flowing through the top 10 health systems in the United States, almost exactly the same. So consolidation is not about the very biggest health systems getting bigger. So what is it? Well, let's look at another myth. Well, it's the for-profit sector of our industry, right? The HCAs and Tenets and community health systems of the world, they've been the drivers of consolidation, right? They came on in the scene in the 1980s. This has been about the for-profitization of healthcare delivery, right? Well, not really.
Right.
Let's look at three different sectors. For-profit is in blue, faith-based not-for-profit in orange, non-faith-based nonprofit in green. And what you're looking at is just one metric of a bunch that we could look at, but who controls the beds? Who controls the beds in American healthcare? Look at the for-profit line. It started 30 years ago at roughly a third of American acute care hospital beds, and today that figure is more like 25%. What's the growing sector of American healthcare? It's non-faith-based, not-for-profit. It's community hospital systems like many of the ones represented in the room today. So what is the story of consolidation in healthcare and health services delivery in the last 30 years? It's about not-for-profit, local, and regional system building. It's about consolidation at the local and regional level, mostly among the not-for-profit sector of our industry. Just one statistic on that. In 2000, not that long ago, less than 20 years ago, 30% of hospital referral regions, hospital markets, were highly concentrated by a commonly used measure of market concentration. Today, that figure is 44%. That's where the needle is moving, local and regional consolidation in the not-for-profit business. That has created names like the ones you see here.
And it's a regional dynamic right now. And as we raise this conversation in different parts of the country and with your teams, it's interesting to hear you discuss the nature of competition, how you expect it to evolve regionally, how one move will cause another move. Obviously, in this region now, we have Advocate, Aurora, and then, Steve, just a couple weeks ago, we had the announcement of Unity Point
right.
and Stanford, which may cause other systems to respond. So there is a sense, and it could be groupthink, it could be something else, that we need to get bigger for the sake of being bigger, or our competitors are that much bigger than we are, we have to respond. But we've heard from some of the organizations that you see on the screen here that we have to hit the pause button. We have to work on execution. We will partner, but boy, we sure don't want any more fixed assets on our balance sheet, because that's what's going to slow us down. And we've run into now, let's call that the diseconomies of scale, I think are here, kind of shaping what's going on inside health systems today.
Exactly. So that's the road we've come down. The relevant next question is, how are we doing?
And so we'd like you to vote on this. And if you're a device or pharma company, just give your perception of the provider world. We're going to give you this same scale after lunch today to ask you to rate your lunch. And let's just see what we get. And we've gotten fairly consistent answers across the country.
It's funny, the early votes were quite skeptical, and they're getting more optimistic as we go.
But distribution, right? We've had a bell curve
Exactly.
just about everywhere. We're early. I think we're early in this. As someone raised to us in one of our audiences, which is, we haven't achieved scale because we've not really been asked to do it yet.
Exactly.
And our message to you today is it's time. And we're going to help you kind of pick out the areas where that's going to be most important to your future.
So that's how you feel about your own organization's efforts to wring value from scale. Let's actually look at the evidence. And so what Bill and I are going to try and do is summarize 40 years of health services research in one slide. So here we go.
With fantastic graphics.
Exactly.
So what the data says, and including research from our colleagues at Vizient and the Research Institute, that we have yet to find value. And in fact, if you dig into the clinical side of what's been going on over the last 10 years, variation within health systems remains bigger than variation across health systems. In other words, we've yet to prove that we can create a better clinical product over time. And it doesn't matter how long your system has been together, how big it is, where it is. This seems to hold up across the country. This will come back in our clinical scale conversation later today, Steve. And then, let's see where the glass is. The message back to us, and let's pause here for a moment, is that we have used our size to generate a price point in the marketplace. Yesterday, what did we hear? What was the announcement yesterday?
So the rules came out from CMS, the proposed rules came out from CMS. It was in your papers this morning. That was the response to President Trump's executive order around price transparency in the hospital business. So you can go out and comment on those rules. And what they're saying is that you will have to report not your charges, but report your negotiated payment rates with commercial payers in a form that third-party vendors and presumably consumers, although that's somewhat of a farther reach, can act on that. Almost certain to be litigated.
Yeah.
The AHA and AHIP, the trade association for health insurers, already on record right away opposing it. Not sure that's good decision strategically, but that's the one they made.
All right, so where do we go from here? It's untapped opportunity. So we do take the glass half full, right, Steve?
Yeah, exactly. So the skeptics say, well, this is the proof that scale in healthcare doesn't work. Consolidation is bad for consumers. The record shows that it hasn't been associated with quality improvement, with greater consistency, or with lower cost. We don't take that view at SG2. We take the glass half full view, which is that all of that opportunity just remains yet to be captured. And so that's really how we want to spend the day with you today, is what's the path for capturing that value through scale that can then prove its merits to our skeptics.
Good. All right, so let's pause for a moment and say, what happens if we're not successful?
Yeah,
if we
so
don't do it?
Before we get too comfortable, we haven't been forced by the market, by regulators to prove the value of scale so far. Why do we think that's going to change? We do think there's a sense of urgency around demonstrating the benefits of scale, because if we can't, there's two sorts of responses we think are likely and are likely fairly imminently. The first, this gentleman with a shovel. So these are disruptors, right? The first risk is that our business will be disrupted. By whom? By the likes of Doc on Demand and direct primary care and insurers steering diagnostic imaging to freestanding centers. All of those kind of small forces nibbling around the edges of our business right now that may not be moving the needle much on revenues or income. If we don't prove the benefits of scale, we think that nibbling is going to turn into some significant disruption. That's risk number one. Risk number two is regulation, right? If we can't prove the benefits of scale, then we're going to be at the pointy end of regulation, and maybe it's in the form of the rules that were released by CMS yesterday, maybe it's in the form of some type of Medicare for all, which is animating the presidential debate right now.
We expect post-2020 there will be states in the country that push plans that are priced slightly above Medicare. I think that's inevitable, and then we'll see how that cascades through the market. You're going to experience both aspects of these issues, which is why we want you to hit the accelerator on your journey to prove the benefits of scale.
So let's go to it.
All right. So first of all, let's define it. And here it is, the great message of today. So while the people in the simulcast are already watching reruns of Game of Thrones, Steve, so I thought we just hit this. Just because you're big doesn't mean you've achieved scale. And I think it's important to put that aside. And we can take both sides of this. There's a path to scale for smaller independent systems. We'll give you an example in a moment. but the idea that we need to be some multiple of $1 billion and have a certain number of sites of delivery, that is not the answer to what we'll have to achieve over the next few years. Scale is a whole bunch of other elements, a strategic choice and how you want to do it. It's situational for your organization, your market, and a promise that we've not yet fulfilled, and it cuts both ways. That's the diseconomies argument that's very much in play right now.
Exactly.
All right. So there are pieces of this that we would say this is the message, which is use the appropriate combination of size and scope to do what? To organize a consumer-based solution to meet their needs on their terms, to change the operational model, and we'll connect that to the workforce message in the course of today. Yes, there is a still untapped ability to tap data to drive better decision making, and relevance to the communities you serve is the ultimate goal here. And for some of you, yes, it's going to be a path towards getting a percentage of the premium dollar to earn back what you're delivering to the delivery system and not put it in the pockets of the commercial payers. But it's not, again, it's not about the size that you're trying to achieve. It's these elements of the organization. You can call these competencies, capabilities. That's more of what we're going to address today.
So you asserted, Bill, that scale is not size. But we're still asked every day,
right.
How much size do I need, right? How much scale do I need? And our answer, of course, is one of those frustrating answers, well, it depends on your market situation and your footprint and so forth. But we also think it turns substantially just on what is your organizational ambition. You might call it your mission, you might call it your vision. We're calling it your organizational ambition. What do you want to be organizationally in healthcare, in the market you serve, however you define that market? For some of you, it may be, on the far left, we just want to take the very best care of the people of our community, however you define that community. That becomes pretty clear then. Any further scale opportunity, any merger, you're going to judge through that lens. Well, is this going to help me take better care of the people in my community or not? If I can't pass that test, more scale is not necessary. Others of you may define your organizational ambition in more geopolitical terms. We have some market area, the 3-state area, the 6-county area, however you define that geopolitically, and you want to be the indispensable healthcare partner in that geography. So anyone who wants to do anything regarding healthcare, they got to come to you. You're the indispensable partner. Well, that's going to define the scale that you need to have. For our for-profit brethren in the industry, they are quite properly animated by maximizing shareholder return. They're going to view scale decisions through that lens. Am I improving shareholder return? And then as Bill just mentioned, some of you are very committed to a population health journey. By definition, then your scale is going to be denominated at some point in terms of patient lives. How many patient lives do I need to wrap my arms around geographically in order to define the right scale? So we would encourage you, as you're making your own decisions within your leadership team and with your board about what's the right scale for us, to start with a sense of clarity, as much clarity as you can muster about what is your organizational ambition and the words behind that. So let's turn now to some lessons from the best. Again, just 3 organizations to start the dialogue we're going to be having with you all day about organizations who have been very successful in wringing value out of scale. The first case study we have today, it's going to come in the form of a video, and it comes from Banner Health. Banner Health, an $8.5 billion health system. They just missed that top 10 list that I showed you earlier. Based in Phoenix, and they serve Maricopa and Pima counties in Arizona, northeastern Colorado. Arguably, Bill, one of the most successful and consistently successful not-for-profit health systems of the last 20 years in both quality terms and financial terms. And I think arguably a big part of their success is how they have leveraged their scale. So the video is from Peter Fine, their CEO, and listen to how he talks about Banner Health as an operating company.
I think about scale from a behavioral perspective, because the advantages of scale comes from how you behave, not how you're structured. And from that aspect, if you go back to when Banner was first formed and I first came in, now almost 19 years ago, November of 2000, and I made a pronouncement at that time that Banner's an operating company and here's how an operating company functions. And chose to put my stake in the ground very early that we weren't going to be a holding company model, we were going to be an operating company, and defined what that was for the organization, and defined it really around a behavioral model. Yes, there are structural reasons why you want to organize in a certain fashion and develop reporting relationships in a certain fashion, but at the end of the day, the advantages come from how you act and how you behave.
Banner Health is not a democracy. It's not a federation of independent states. Banner Health is an operating company. And when Peter Fine came in as CEO almost 20 years ago now, they were in significant financial distress. He had a turnaround on his hands. And he used that crisis as an opportunity to put a stake in the ground on how that company was going to operate.
So let's go to another example. This is on the clinical scale discussion. MultiCare is in Tacoma, Washington, but now a statewide system. And they've gone after surprisingly scale in behavioral health. And if there's an area of clinical care that we think would both benefit from being bigger and better, it's obviously behavioral health. And a lot of you have made some progress here. So we spoke with their director or their service line director about the efficiencies they're chasing. But now they are the largest provider of behavioral health in the state of Washington. They just opened a joint venture behavioral health hospital with their largest competitor, which has some great sense to it, right? So let's find areas where we can collaborate and we'll still compete with you at the same time. And now it's led to broader partnerships around the state, but just to track their progress just over the last few years by investing some significant dollars in behavioral health. Their revenue has grown from 20 million to 190 million. They count the unique patients served, so they're up to 50,000. They're humble, as most of you are, in saying we're still working on variation and what it means to be a consistent provider of behavioral services. But because of what they've taken on, and now because of a partnership with a federally qualified health center, they're getting a preferred reimbursement rate from the state for Medicaid. So for them, behavioral health is a break-even plus business, which gives them more reason to grow. So there are positive solutions out there on the clinical side. And we'll explore that issue in a talk this afternoon.
I love the example, Bill, of, again, MultiCare and Franciscan, their partner in that behavioral health hospitals. Fierce competitors, right, in every other clinical field. They didn't feel competitive on behavioral health. They just had a shared sense of pain around services they couldn't provide at scale to the community, and they decided to partner on that.
And it's interesting that this will relate to a discussion that will be going on tomorrow, but many of you have now kind of gone down to that next step of social determinants of health, community health improvement. Your scale journey has gone to that next phase of what other aspects of health do we take on in the markets around us. And it's about time, right? So
Exactly.
We should do it.
So here's our third best of the best example. Blessing Health System, Quincy, Illinois. So this is the counter narrative to size as a path to scale. Blessing Health, and we have some representatives from Blessing in the room today. They heard the siren song of consolidation and said, "No thanks. We're gonna pursue a different path." So first, let me orient you. So Blessing is based in Quincy, Illinois, a beautiful little river town on the Mississippi, about maybe 3.5 hour drive southwest of here. A 300-bed or so hospital in Quincy. Medical group, and a small critical access hospital out of town. So several years ago, Unity Point, who we raised earlier, came to Quincy and acquired what was then the largest independent medical group in town, right? That's the shot across the bow. And then Unity Point came to Blessing and said, you know what, you ought to just join us. You know, why don't you just merge into Unity Point? And so Blessing went through its own due diligence process. They had the discussion with their board, and they decided, no, I don't think so. I think we're going to pursue our own path. They had a strong balance sheet. They had a very strong reputation in the community. They had a loyal group of physician partners in the community. They had a strong quality reputation. They thought that they could find their scale and be relevant in their market in a different way. So what did they do? Well, they joined the BJC Collaborative. We also have representatives from BJC in the room today. So this is a collaborative of, I think, 13 health systems now, I believe, in the Midwest. Not a merger, not an full asset merger, but a collaborative that can gain benefits through their shared scale around purchasing, around clinical programs. So this was part of the recipe for how Blessing achieves scale without losing their independence in a local market. They've also impressively, in the last several years, invested heavily in multi-channel access to ambulatory services through virtual consults, through a network of ambulatory clinics, through retail clinics to improve access in the community. They've built market relevance through direct-to-employer contracts. Last year, Lisa and I had a bit in our conference around direct-to-employer. Blessing is one of the most successful on this front. When I was at their board meeting last year, who's on their board? The CEOs of local employers, right? And they could not have been more effusive about the local health system, who was actually focused on solving their problems. And they now have 11 or a dozen direct contracts with local employers. Blessing is growing, they're profitable, they're focused on execution, not on size. I love this little health system, Bill. They know who they are, they're good at what they do.
So they answer the ambition test, the relevance test, and partnerships, right? So there's an enlightened path.
There are a lot of ways to scale.
Exactly. So let's tie this up here. There's a journey so far yet to be determined, right? And we're more of the glass half full view of what's going to happen. And then we do fully believe there are independent health systems that will do well. We have to define what exactly it means moving forward beyond assets and even the access channels that many of you are still putting in the marketplace now, beyond pricing. And let's find a way forward. Let's align it with your ambition, and let's tie it to the execution challenges that are on most of your lists right now. And we'll draw your attention to several of those today. Your path towards value-based care, towards scaling your workforce in new ways, towards building a different sort of clinical care delivery model, and innovation as well. So Steve, let's pause there, see if there are any challenges, rebuttals, and thanks so far, guys. Thank you.
Okay, what questions do you have? We have a question right there. Thank you.
Hello, Annette Kenny.
Hi.
Tell us who you
And
are
could you
and where
tell
you're
us your
from.
Annette
name
Kenny, Edward Elmer's Health.
Oh, God. Okay.
We've known each other for a long time. You mentioned that regulations could drive additional scale, but there's also the flip side with FTC. And sometimes the greatest scale opportunity may be in contiguous service areas, yet that's the biggest FTC challenge. So do you see any lightening up or changing of FTC regulations coming down the pike to allow organizations to take advantage of that kind of scale?
Yeah, who knows? Because the government's kind of at war with itself, right? On the one hand, they want us to be more integrated. They wanted us to deliver value-based care. On the other hand, they are fearful of anti-competitive scale in local markets, and that conflict has not been reconciled. And I don't see any path in the near future to that conflict being reconciled.
I think that's right. I think there'll be waivers for things that make sense, particularly in Medicaid and at the state level. But the FTC and Department of Justice have been remarkably sort of independent of the party in power, and there still is this view. And we have pharma and device companies in the room. The payers have a very skeptical view of what we're trying to get done. But certainly for some of the innovations that we might be able to get done, maybe some lightning there.
Waivers will be the path.
I think that's right.
Yeah.
Good question. What else?
We need to amp the caffeine
Joel, do we
supply.
have questions online from the simulcast viewers? No questions yet. Simulcast viewers, please be sure to type those questions in. We can receive those and read them out here in the room. Well, gentlemen, I have a question for you because I'm not going to let you off the hook that easy. Why the positive rosy picture? We could be more skeptical here. We've seen a lot that has pushed us to say that really the only thing that's come out of scale and size is higher prices. So do we believe we can do it?
I don't think we have a choice.
Exactly.
I think it's here and it's time. And to put the cards on the table, and Steve and I talked about this, Health System Work with the CEO is now being very open with the employers in his state, saying, look, here is the subsidy you're paying to us above Medicare. It's about $500 million a year. Thank you. We're covering what the government payers don't give us. You're covering that as employers, but let's have an open discussion of the value you're getting. That's where I like the direct employer discussion, Steve. But it's here, it's time.
I think that's exactly right. Healthcare is 1/8 of the American economy. We're one of the most fragmented sectors of the American economy when you think of, retailing and banking and so forth. So scale is the right path to deliver what we have to in terms of value and clinical quality. And we don't have a choice but to figure out how to make it work.
Good. We have a question here. If you could introduce yourself as well.
Yes, Elliot Clark from Merck. Good morning. Thank you all very much for the session. So you actually just mentioned it, but in the Blessing example, you mentioned the direct-to-employer contracting, and that obviously being a sort of different form of disruption. You think about sort of, essentially cutting out a payer, and sort of those dynamics being balanced throughout the marketplace. Do you all foresee that happening more and more? Obviously, it has to fit the mission of the organization, but can you all speak to that dynamic a little bit more?
Speak specifically to the direct-to-employer contracting? Is that what you're saying? Yes. Yeah. So we think there's a great opportunity there. And again, that was a major segment of our Executive Summit conference last year. There have been, frankly, a lot of fits and starts, though. A lot of you who've gone into some form of direct-to-employer relationships, but it's hard to use the word, it's hard to get to scale in those. And it's not about, as Lisa and I talked about last year, it's not about going into a 2-year product development cycle and coming up with a set of employer solutions and rolling them out to the market. It's much more about listening very carefully to local employers, partnering with them to craft solutions for them. And not just in one model of we're going to cut out the payer. There are a lot of ways that you can solve employers' challenges through direct relationships. So we remain bullish.
A couple more points here. Where it is happening the most today is in smaller and mid-sized markets, where there's an ability to kind of trade off access for price without sacrificing network sufficiency. Large markets, it's very hard to get this done. And then what we've heard back from you is we still have a ways to go for us to talk with the benefit managers and the brokers to bring them into this equation, because ultimately they dictate how this is going to play out in most markets.
We do have a publication on that topic as well. I believe it's located in the hallway, but if not, you can always ask our registration desk and they can send you a link to that copy. We do have a question online from the simulcast. Joel?
We do, from Steve Tracy at Geisinger Health. The question's around sustainability. How do you ensure that this remains in focus with the rapid pace of consolidation and scale?
Sustainability itself?
Not sure I'm quite with it. Sustainability, we can answer it however we want, Bill.
Yep, go for it.
Exactly.
I'm not sure I entirely understand the question. What I worry about, though, and maybe this is a tangential answer, is that most of you live off of what you make a commercial payment, and your sustainability path is tied to that. That's very touchy right now. Illinois is, let's call it, maybe 140% of Medicare. Southern Wisconsin is 300% of Medicare or higher.
Denver.
Same with Indiana. Right. So that dynamic across the pricing reimbursement thing is directly tied to the sustainability question.
And frankly, the message of finding ways to wring value out of scale is an important ingredient to how we're going to get out of that conundrum of floating the enterprise on a shrinking portion of commercial reimbursement. It's part of how we're going to solve that riddle.
We didn't bring up rural, small hospitals. I do think there's a fundamental sustainability question on the table for those organizations, critical access tied to workforce. And it's going to be a very tough one for us to solve. And we suspect there's going to be a different reimbursement, different payment model for rural providers over the next several years.
All right, gentlemen, thank you so much. One more question?
Great.
Real quick question.
Bill, Steve, Brad Partridge with Ascension, and I thought maybe I'd share a few observations.
I hear you have some scale at Ascension.
We do have some scale, and we're on your really cool, fancy animated slide that you had, which was really impressive.
Daughters of Charity back in the day.
A few other things I'd say. One, debt financing. Having the scale to kind of get really favorable, best in market rates on your bonds. And I'd say that's something that's really helped us over the years in bringing other systems in that have had higher bonds, and we've restructured that debt and increased the sustainability of those organizations over time. That's one. Two would be, really gives us a platform to innovate, and if we fail, we're not going to sink the ship. Having that kind of broad national scale on new care models and business models, that's number two. Three would be to kind of build internal capabilities that we used to pay others to do. That generates value and cost savings, and also for us has given us the platform to kind of commercialize those capabilities outside of Ascension and generate other revenue. And then the fourth one I'd just say is scale kind of gives you a voice on Capitol Hill and the ability to move the dial from an advocacy perspective. So any comments on those?
We couldn't agree more on all four of those, and we couldn't have said it better.
I wish we had, actually.
And I wish we had. But I think now the opportunity is those sorts of advantages, which Ascension demonstrates so well, is then translating that into a more reliable, consistently high quality, lower cost clinical product. Completely agree on all four of those. And Ascension is a great demonstration of all.
Economies of skill, which is I think a McKinsey term. I buy it. But the other thing I've heard on the table, Brad, of late is that most of you, for bond rating reasons, a lot of you have an enormous amount of cash on your balance sheets. And I think there's a question now: does that make sense? Can you deploy that in different ways to create value? I think there's a financial pressure that will come our way as well. Great stuff. So
we can ask our friends at Apple how to deploy.
Well, thank you so much, gentlemen. I love that you're asking the tough questions, and I love that you're also providing your own context and solutions as well. Please keep that coming. We love to have that interaction throughout the day.